Good morning. Good
Good
morning.
morning.
Wait, I wanted to show this banner. Okay, welcome. Thanks for joining us. Please like and share the video. Okay, we're going to run that for a minute. All right, okay. All right, good morning. Good morning. Okay, let me just start off. I got on my orange and gray and white. Who they? The Bengals. I didn't know y'all was still in it too. So don't tell me and you gonna have to battle at some point if it's the Bengals versus Philadelphia.
That would be
That
something.
would be all something. We gonna have to do a whole pregame Super Bowl party online. I
Yes.
saw that. I said, whoa, wait a minute. I got people over there now. Don't tell me we about to have um a whole a whole thing. I don't understand. I don't
Yep.
understand. All right. Well, welcome everybody to the Saturday morning tea where we just discuss everything. We discuss health information, news, education, certification tips, and entrepreneurship. Also, um, some regulatory guidance to help you in your work, to help you in your business in your work. And that's kind of seems to be the focus here lately, but yeah, but it all ties in together. There's a method to all of this madness. I am Clarice Warner. I am the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And let me just ask you, first and foremost, do you know what it takes to be a certified marketable? That's the word I need to emphasize. Medical coder. Well, before I introduce my co-host, let me share with you information on a free 99, y'all, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right. So if you are in Clubhouse, and welcome everybody in the Clubhouse. We got Kim, Renee, Shay, and Tay. Wait, I feel like I'm rhyming. Hold on. Those are some bars right there. Welcome. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, then click the link in the Clubhouse. If you are joining us via YouTube, Facebook, and LinkedIn, you can always check out the link in the video description. It's down there. I promise you. It might be a little congested in there, but it's down there. Keep scrolling. You'll find it. I just had so much information I want to get out in such a small space. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. I still love that. That is the bomb. That is the bomb.com. The coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I'm from Philadelphia. I have been in healthcare for almost 30 years, and I'm transitioned into HIM in 2014. During the pandemic, I created my company, the Coding Nurse LLC, where I help other nurses and other healthcare providers and people in healthcare who have clinical experience transition into the wonderful world of HIM.
All right, now wait. I heard a little limp there. Okay, you better do it. I pay attention to all kinds of details. So I heard some things like, well, wait a minute. So not only are we doing it big with the new beautiful background. I love that. I love those
Thank you.
colors. I love it. But we got new introduction. You better come on. I love it. I love when you just add to whatever it is that you had and you progress. I love that. I love that. For anybody, for everybody. I love it. That
That's right.
shows that you potentially see opportunities for growth. And that's what that is. That's just growth.
That's the
So I
name of the
love
game.
it. Every time, when I go back and review these videos, I'll be like, Lord, I could have did. I should have did. We should have did.
Oh.
And I was like, well, we'll do it next time. Or we'll incorporate it or figure it out. So it's all about the growth. And I love that. Okay. So, before we jump into our discussion today, and I feel like it's a doozy. Let me remind you, if you are on Clubhouse and you want to join in and add to the conversation, just raise your hand. We'll see you and we'll bring you to the stage. Or if you just have something that you want to say hi or have some additional thoughts or even unrelated thoughts, but it's all in the family, feel free to come up to the stage and we will definitely allow you to speak. So don't be shy. Remember, your opinion matters and is welcomed here. Also, for my Facebook, YouTube, and LinkedIn friends, please use the chat. Y'all know what to do because y'all like to keep the chat buzzing. If you have a question, please type Q first so that we know it is a question for us and we don't miss it. So let's get into it today. So for those who are joining us today, we are talking about preventive actions not to harm. Folks in the medical profession has taken oaths not to harm. You got providers who have taken oaths not to harm. But did you know hospitals and other inpatient facilities should not harm either? And so we're going to talk a little bit about that. And then kind of think about what is it that we as health information professionals can do to assist. So for the past few weeks, there has been a lot of emphasis on Medicare Advantage plans. They have been all over the news, in news feeds, blogs, LinkedIn, Facebook, YouTube, you name it. Folks have been all over Medicare Advantage plans and the recent proposed guidance and clarifications that were directed towards them. Word on the street is, though, that a report has been released from the OIG that details harm and adverse events in the inpatient setting. Now, I am not 100% certain about the report's release date. I've seen a couple of things that were released on different dates, and I'm like, well, wait, you all said last week, you all said yesterday, you all said last month. So I'm not 100% sure when it was released, but I do know, and what I am certain about, and what I can confirm is that the OIG has revised a report from CMS and AHRQ, which is the Agency for Healthcare and Research and Quality, to do a deeper dive and get some information about a toolkit. So I'll bring that up so you can see that. And I said, oh, well, we doing this now? This is what we doing now? Okay, so it's the toolkit for identifying adverse events through medical record review. And so this came out before, or some of the work started before. So now they have revised it. And it's going to come through the Office of Evaluation and Inspections. And it's expected, the report is expected, or the toolkit is expected to be completed this year. So it says the OIG has found that patient harm is common among Medicare beneficiaries in a range of inpatient healthcare settings. Federal regulations require that hospitals and other healthcare facilities identify harm such as adverse events and work to reduce these events. CMS OIG will use guidance materials and tools created for our prior studies of adverse events to develop a web-based toolkit, for identifying and measuring adverse events to assist healthcare facilities, government agencies, and researchers in their efforts to improve care. They will also share the resources that they developed and used in their adverse event studies to aid hospitals and other researchers in their own efforts to identify and monitor the incidence of adverse events. That means how many times that these things happen. The toolkit will provide standard definitions for most event types, lists of triggers to flag patient harm, suggested guidance for reviewers, and considerations for clinical decision making. So yeah, all of that is prompting all of this. So it's a lot going on in these streets. Mr. Jesse, did you want to comment?
Not yet.
Oh. Let me get my tea ready. So, with that being said, there have been a lot of talk in the provider community about these this report. So, some folks have kind of written the OIG and their reports off, like it's too much. They're sending too much information, or it's not something that we need to be paying attention to. I beg to differ, and so do others. So, in an article written by John K. Hall, MD, JD, MBA, FCLM, which I don't know what means, and probably a fellow of some sort, and FRCPC, which is also a fellow of some sort. He kind of brings out the information from the released OIG report on harm. And he says that it's one that folks really need to pay attention to. So what they did was they looked at 834 eligible discharges and any associated 30-day readmissions. And this happened October 2018. Now, before you be like, how old is that? Bear in mind that oftentimes you don't get data. You don't get instant data. You don't get data from like last week. Sometimes it takes a couple of years for all the data and the facts to all the information and the data that you need to be there. So you would want to sample at a time point when all of the pieces are there to validate your study. So let me just give you that from my public health experience and compliance reimbursement experience. So the sample covered only 629 of approximately 5,500 hospitals in the U.S. So there were over 1 million Medicare patients discharged during October 2018. And so even if all of the 834 discharges were associated with some form of adverse event, that would represent an occurrence rate of 0.08%, or 8 per 10,000 discharges. That's a lot. That is a lot. Okay, so let's see. They said there were several cases of intracranial or cerebral vascular procedures, and one of the cases was a lung transplant. They said these procedures are not available at many inpatient prospective payment systems, acute care hospitals, and this kind of selection bias makes the results appear maximally unfavorable to all, and he emphasized all providers. Now, nurse screeners were used to review the records, and they used the Institute for Healthcare Improvement's global trigger tool, which I said I was going to dig a little deeper into that, and assessed present on admission indicators. So nurses, we talk about nurses all the time, don't we? Nurses discovered 393 qualifying records. They also had some physicians to help out, and there was a team of 6 of them that reviewed the records and found 299 related issues. So they had 115 that had adverse events and 185 had temporary harm events. Now, that gives you an incident of 0.03%, or 3 per 10,000 discharges. The largest category that was found. Anybody want to guess? Not you, Mr. Jesse. You can't guess because you know. Anybody want to guess? Wait a minute, let me see. Do I got anybody in the? Good morning, everybody. Anybody want to guess? Nobody's guessing. Okay, I'll go right into it. So the largest category was medication-related events. Okay, and that was at 43% of the sample. Patient care events were 23% of the total. And then the most significant components in the patient care events were skin injuries. Y'all know what those are. And falls. So the next category was surgical at 22%. Let's see. Over half of the events in the surgical category were determined to be not preventable. And finally, infection was 11% of the events. So they felt, or he feels, the study is biased and probably uninterpretable. But we still need to kind of talk about it. And there are 3 reasons why he feels folks need to be talking about it. First, the OIG will tell folks all their good news. And I'm saying good news is tongue in cheek. But they will say that they have a finding of 25% of patients experienced harm, much of which was preventable. Next, the report actually includes IPPS and non-IPPS claims. That means that your Medicare Advantage plans and the cost to them are included.
All right, yourself.
I'm Brian. I'm a Cooper Roofing.
And then
I called.
You also.
Wait
a minute.
They're up there now.
Mr. Jesse,
Okay.
let me mute you.
Oh, I'm sorry.
You're fine.
I meant to mute myself.
You're fine. Okay. And the third part is that he said buried on page 289. So he sat and read the whole thing. Good for him. Other report is the claim that, quote, we estimated the cost for all events to be in the hundreds of millions of dollars for October 2018, end quote. So annualized, that is $1 billion over the year. And CMS also concurred with the findings and recommended a broadened list of hospital-acquired conditions. So that's where we come in, because now they're going to expand that list of hospital-acquired conditions that we need to make sure we are aware of, and the indicators for, and the coding for. The Medicare Advantage plans will almost certainly respond with aggressive attempts to reduce payments for preventable harm. So if they see these hospital-acquired conditions, they can say, we don't have to pay for that because the patient received these conditions within that facility and it wasn't something that they had. So that's why present on admission documentation is important, and the present on admission status. So the author, Mr. Hall, also Dr. Hall also states some things that we can do to prepare. So first and foremost, we have to make sure that documentation and the diagnoses are documented. He said many of the medication events cited in the report were related to delirium or other acute mental status changes. Several events related to acute kidney injury, and they also saw encephalopathy, delirium, and acute kidney injury reliably denied by payers and contractors. He mentions you're probably going to be penalized for them, but you still need to make sure that they are accurate. And if they exist, then accurately document them. Second, plan for medication errors to be aggressively reviewed. Don't document an association between a medication and an event unless you're certain they are related. So this, of course, his audience is primarily providers. However, we know with the CDI teams and having to go back and query, this is information that will be important in that work as well. So he also says, and you should also explain when they are unrelated. So again, documentation is so we talk about that all the time. It's so important. And then I already mentioned the place of stat or present on admission status, especially for skincare and infections. Don't just pull up a template and click the normal boxes. Make sure that all the information is there. And his final thought was the OIG just handed CMS and Medicare Advantage a brand new playbook to begin their audits and reviews. Okay. Mr. Jesse, any thoughts there?
I got a bunch.
Do I need my tea?
Hold on to your mug.
Oh, Lord.
So, what I thought was interesting was the sample size is just ridiculous. And I just think that this going to be what I thought about, my musical references. I just thought about Michael Jackson. You just want to be starting something because
Sir, I'm gonna need you to start sending me them early so I can have like a playlist of all of these. Okay, go ahead.
because to pick something, to pick a small sample size like that, and then try to extrapolate like it's uh, a lot more prevalent than what it really is I think it's problematic because let's just pick the largest um, segment, which is medication errors. They didn't give an example of what are they considering a medication error. Now they tried to link it to acute kidney, or so are they trying to say that the medication errors caused acute kidney injury and delirium or encephalopathy, or are they in addition to? Because I thought maybe they were like the 23%. Because as somebody who does CDI every day, I can tell you like almost every older person that comes to the hospital will have some kind of uh, delirium, which is related to Alzheimer's. We know that infections in older people can affect their mental status.
Mm-hmm.
So they have encephalopathy. And for encephalopathy, you really just have to document a change in mental status. And that could be the documentation, or, their caregiver might say they're alert and oriented times 2, but in the hospital, they're alert and oriented times 1.
Right. And anything
That's
as
a change.
simple, something as simple as um a urinary tract infection can wreak havoc on
Exactly.
an older adult.
And then, especially when you have older adults who come to you from long term care, when you talk about like the sepsis criteria, which they use the SIRS criteria, which is systemic inflammatory response syndrome, and it's 4 criteria. You have to either be tachycardic, which is your heart rate above 90. You have to be tachypnic, which you have to have your respirations above 20. You have to have leukocytosis, leukopenia, some kind of fluctuation in your red blood cells, and white blood cells, and there's another one, temp. You have to either be febrile, or you have to have like a below average temp. So you only need 2 of those criteria. So if you have if you have a UTI, you can have a fever,
Mm-hmm.
and you can easily be tachypnic, or you could easily have leukocytosis.
Mm-hmm.
So then you get flagged as potential, as a possible sepsis. Sometimes they'll just say sepsis, and then they'll do blood and urine cultures once while you're inpatient. But then even with that, like there's still other criteria that you look at for sepsis, like procalcitonin, and a few other lab values. But also when it comes to acute kidney injury, if that same long-term care patient hasn't been drinking for the past several days and they're dehydrated, that can give the appearance of acute kidney injury, because your BUN is going to be high, your creatinine, your serum creatinine level is going to be high. So that will meet the criteria. So it's a lot of moving parts. It's a lot that goes on to come to the conclusion that somebody has acute kidney injury and or sepsis. Because if you have sepsis and acute kidney injury, if the provider links them, then that's acute kidney and that's severe sepsis. So it's a very, very slippery slope. And I don't know what kind of criteria they're going to use to definitively rule out some conditions over others, but it is getting ready to be a very serious fight for these reimbursement dollars.
Yes. So the they holding them bags. They done got these bags and they're about to hold onto them and hold onto them tight.
And
And
then
go ahead.
my last comment, the whole 43% medication error, I don't know. I mean, I would have liked for the article to have provided more information, because this is going to be fodder for these people, because I don't know if you heard, but the feds just busted a ring of, I think is, well, there's several nursing schools they have found where over 7,500 people paid for fake nursing credentials to take state exams.
Sir,
And
where is that? That will be our topic next week. I'm gonna need you to sit that.
oh my God, it is, when I tell you, it is, Nurse TikTok is on fire.
Oh, once again, and they're fun. I love when Nurse TikTok and the nurses come out, because woo, baby, like when they rallied around the lady who was being criminally charged.
Yeah.
Yeah. So yeah, we gonna talk about that. I love that. So yeah, hold that.
So those, with this coming out, and then on the back of that, it's getting ready to be something.
The whole healthcare, and we've talked about this over and over again. The whole landscape of healthcare is just about to probably implode, and because people are like, you know what, I'm not doing this. I'm not. You're not, and I'm not. Oh my goodness. Oh, wow. So, as a result of all of this information coming from the OIG, there was another article that kind of talked about, that piqued my curiosity, from Dr. Ronald Hirsch. And I've talked about some of his articles before, but he talked about, wait a minute, 1, 2, 3, 4, 5, 6. He talked about the doing no harm, and there was a Choosing Wisely and the Society of General Internal Medicine released 5 updated recommendations for various conditions, and he said that, that these are from professional societies offering what they are commonly called as, quote, things we do for no reason, end quote. And so he talked about, so in this particular list of things that they have, it talks about advice for asymptomatic healthy adults that do not need a yearly physical exam and labs. He talks about routine pre-op, well, this recommendation, routine pre-op labs before low-risk surgery that are not necessary, that physicians should not perform cancer screening for patients with a life expectancy under 10 years. PICC lines should not be used for patient or physician convenience. And type 2 diabetics not on insulin do not need to perform daily home blood glucose monitoring. And so he says that the reason why he brings this information up is because as providers and healthcare professionals overall, all have a role in ensuring that medical care that they provide to patients is appropriate, and that millions of dollars are spent on these low value and potentially harmful, the theme for the day is harm, interventions, and all money that can be spent on better improving health equity. I concur with that. And reducing food insecurity. I definitely concur with that. And other things. So he said, now one thing he mentions about the diabetes recommendation is that he stopped recommending that his patients with type 2 diabetes check their glucose every day about 15 years ago. Even though the studies show, because there were studies that showed it was not beneficial. And so he sent all his patients to a diabetic educator to learn about diet, etc. And one of those patients came back and said, quote, "The educator taught me to check my finger stick glucose and to check it daily. She said you were old-fashioned and up-to-date doctors recommended daily checks," end quote. And so when he sat down with that patient and explained the evidence, that patient was ecstatic and happy not to have to buy the testing supplies and stick their finger every day for no good reason. All right, so there's some evidence behind that. Now, before you all with type 2 diabetes decide stop doing your checks, make sure you check with your physician or bring up the article. Anyway, so then he also goes into some of the things that have happened as a result of the article that Dr. Hall referenced. And so he said, how the OIG, again, will cite that figure of 25%. He said there is an easy way for providers to reduce hospital harm. He said we should stop treating patients' illnesses. And that stuck out to me because I've had several conversations related to that. He said if a patient with decompensated heart failure is given diuretics and develops low potassium, that patient is, quote, harmed, end quote. Yet there is no way to 100% prevent hypokalemia in this situation. Doctors routinely supplement potassium, but there is no direct dose effect relationship, and giving too much potassium can cause harm in itself. So if a patient gets chemotherapy and develops the expected bone marrow suppression, they are, quote, harmed, even though that cytopenia also demonstrates that the chemotherapy is working. So there is also the issue of hospital safety that was recently highlighted in an article in the New England Journal of Medicine. And so he said it's critical that these studies be analyzed carefully to properly balance the risks and, quotes, rewards of medical care. And then he also said, who knew it was so complicated? First thing I thought of was our last week, it can all be so simple. But yeah, so those were some of the thoughts around what is happening and why folks, or you may be hearing conversations about harm, how to prevent harm, and things that we need to do. Let's see, we got a comment. Good morning, Miss Team Viewer. I love when you all drop these gems on healthcare. You are welcome. You are welcome. Okay, so Mr. Jesse, any additional comments?
When anybody talks about I don't know, like when they say harm reduction, I don't really think that somebody who takes medicine for blood pressure and if their potassium drops, I mean, is that really harm? Like that's a side effect, and it's not a fatal side effect. So I don't know. I just think that it's a little, I don't know, it's a little too perfect world for me.
Well, and that's why he has the harm. He's quoting the harm because according to the various tools that could potentially be used or your protocols, then if it's out of alignment, if it doesn't fit nice and neat within that box, it will be considered harm, to your point. So yeah, I think that's why he actually put those things in quotes. But I thought it was interesting. And I thought it gave all of the information was interesting and kind of gave some food for thought, not only for health information professionals in both the CDI space, but in the medical coding space as well, because this then, remember, we always talk about understanding the why. Why are we doing the things that we're doing? And so in the event, you start, like I said, you start hearing some different conversations, or make sure that you are, being particularly mindful about this condition or that condition, and so on and so forth, when either coding these cases or reviewing these cases in CDI. You see the why behind, because of this report, because of then the information that's going to be generated from the report, the education and discussions that will be had by providers on this report. So you see how it continues to, it's the gift that keeps on giving. So they give you the gift of report, but from it comes all of these additional um, uh, development and work, if you will, because now you have to do probably some additional work around it. But all of these things come from that one particular report from the OIG. And that report came about because there had been probably some discussion, or somebody had some questions, or maybe there were someone, made some calls anonymously, maybe, I don't know. I'm throwing it out there, but someone may have had some issues and done some reporting, and they were like, well, wait a minute, if this one reported and maybe that one reported, let's take that. They'll do a kind of off the record cursory review to see if there is something there. And once they say, well, wait a minute, there may be something there, then voila, they go all guns blazing into it and figure out and find out what they can find. And then a report is generated. So yeah, I think this is something that, and if you don't hear the information in your facilities, or, from your providers, therein lies an opportunity for you to say, hey, have you all heard about so and so and so? Or, how does that, is there any potential that this may impact our organization, or is there any potential that this may impact the dollars and where the money resides over here? So again, marketability, bringing information to those where it counts. And when you start talking money, everybody gonna stop and listen. Like, well, wait a minute. Well, what did you hear? Well, what happens, and what we need to do, and what and who and where, especially depending on the size of that money. So just some food for thought, and some gems and tea to spill to assist you in those endeavors.
I think that continuous improvement is a must in healthcare. So I get, you have to reevaluate everything, because there's a lot of policy and procedure that has been implemented as a result of that exact same kind of thinking. But I just wonder, like, just it's kind of an interesting balance, because I think that where healthcare is moving, especially with the healthcare shortage, and I think that with technology advancing, I think that more checks and balances are going to be more automated and left to AI, as opposed to like human intervention, because it's just not enough people. So I wonder what that's going to look like and how it's going to play out.
And to your point, these AI discussions are on fire. Do you hear me? On fire. And it's gonna, I agree, Dr. Talk Active mentioned, it's gonna be a mess. It is. Because while I think for me, my experience with using some AI, because I've dabbled here recently to see, well, what is this all about? Let me take a look. And while it helps with speed, sort of on the front end, you still have time, or it helps reduce time on the front end. Let me say that. But there's still a cost, because you have to then take time to validate and verify that the information that you are getting from the AI monster is correct. And I think people are missing that piece. You still need to have somebody's eyes on it to validate that's where, I feel like regardless if everything shifted in the next 2 years, that we're going to use AI to comb through all of these records and provide the codes for them. Somebody needs to validate that. If I was the provider and I was using AI and I was using that, there is no way in the world I'm gonna sign off on any claim that's going out the door if somebody didn't validate. Because again, whether I use AI, I use it. I am ultimately, as the provider, ultimately responsible for the accuracy of any information that I send on a claim. Period. And I would want to make sure and feel certain and confident that that information was correct.
Oh, I agree. I mean, I see AI all day, every day in my job, because when I open up a new case, before I even look at anything, there's a whole list of suggested codes
Mm,
that have been generated.
mm.
And you have to um I mean, you can't rely on it. You certainly cannot, because case in point, I had one last week. They had the wrong type of diabetes. They had suggested they had all these codes for type 1, but it was type 2, because it saw was IDDM. But insulin dependent diabetes alone does not constitute type 1. So you have to use the default of type 2. Then when I read through, it was like one person said type 2. But you have to follow established guidelines, and then sometimes even for PCS procedures, it'll be the wrong approach.
Mm.
And I had a case yesterday. The person had biliary dyskinesia, but the surgeon spelled dyskinesia wrong, so no code was generated. And then there was a whole procedure that was missed because it wasn't worded. You had to piece it together what was done, and it totally missed it. It only had one PCS procedure there, but it was actually two that was done.
So they generate the PCS procedures as well.
Yep.
Wow.
Sometimes you'll have a whole code. Sometimes you'll have like the body part will be missing, or they'll have question marks for the body part and or the approach.
So again, that requires someone to take a put their eyes
Absolutely.
on the documentation to pull all of that to make sure that to supply the accurate code. That's, oh Lord, yeah. So again, I mean, you pay to me you you're paying double because you're paying the money to use the AI software, but then you also have to pay the validator. And maybe in somebody's mind they're thinking, well, a validator is less expensive than but no, that validator needs to have coding experience. That validator should be certified in coding. You wouldn't want somebody to just be like, oh, well, this ain't here, well, let's just do it. No. So I don't I'm curious as to what that model looks like, what that business plan looks like in the coming years with AI inclusion. Stephanie says, very true, Clarice. In the world of quote, if it's not documented, it wasn't done. Yeah, that was my world forever for years. And I used to use that all the time. Seems to be changing to it was documented, but was it done? Exactly, because somebody needs to validate. And I think, even with electronic medical records, we were all up in, at least I know I was, all up in arms related to related to the copy, cut, and paste. But this AI crap has just is gonna make that seem like a cakewalk.
Well, because I think with all things, it fixes one problem, but it creates another one.
Yes, yes,
And what I find with these cut and paste templates is, the bottom line is people just don't read.
that's true.
That's really that's really what it all comes down to. And because like in the perfect world, everything like in a discharge summary is supposed to be like the Cliff Notes version of why somebody was there.
Mm-hmm.
That hospital course that paragraph should wrap everything up like a cheap suit. And everything that was diagnosed should either be confirmed or ruled out. All these possibles, and it's never, ever, ever done. And if you don't want to do it that way, then the providers have to read the notes and they have to update what is going on. If something has been ruled out, why are you still saying possible sepsis 4 days into admission when the person has positive streptococcal blood cultures? It's not possible at this point. They have streptococcal sepsis. Why are you still saying it?
Mm.
Because you cut and paste.
Mm-hmm. And
Well,
didn't
copy
read
and
what you
paste.
copy, cut, and paste. You didn't
No.
read none of that stuff. And they used to get caught, um, which is going to be interesting, even with evaluation and management. You oftentimes would get caught in the exam. And so they're copying a full exam, even though they may have done some components of it, but they wanted to get the points. So they did a full exam. But in either the history of present illness, or even some of the assessment and planning that they did contradicted the information that they documented as far as the examination. So they would get caught there. But E&M has changed, and now you are just looking primarily at, now you're supposed to still document and have a history and exam. Again, those history and exam elements just don't level the service. It's all based on your medical decision making. And so it may be a little more, it won't be as easy, I guess, if you will, unless you go back and review all of the things to make sure it's certain that the objective information is there to support what was documented in the medical decision making. But who's going to do that? They're not going to do that front end coding. They're just going to look at this. Oh, it matches
Right.
this, that, and the third. Boom, here's the code, and off it goes. But again, leaving yourself open for the audits that will come
And
as a result.
and then like we could spend a whole month talking about these queries based off of documentation, because if documentation were better, it would eliminate queries, period. That's the whole
Period.
purpose.
Period.
But because what is so interesting is what frustrates me the most so far is you have, when someone is in the ER, of course they're going to be, of course things need to be ruled out, of course there's going to be a lot of uncertainty, but at some point in time you are supposed to, if you don't agree with something that the ER provider documented, you have to rule out, you have to rule it out, like, so we don't have to go around and try to figure it out. Because case in point, I had a patient who was diagnosed with acute on chronic diastolic heart failure in inpatient, but in the ER they were diagnosed with acute on chronic systolic heart failure. So of course, the suggested codes being what it is, it suggested acute on chronic combined systolic and diastolic. So I can't do that because nobody inpatient mentioned diastolic. I mean, systolic was only diastolic. So I wasn't, so I had to write the query and I had to, since it was mentioned, I could, since it was diagnosed, I could list the code. So what I ended up doing was I just asked the doctor to clarify the type of heart failure. So I gave him four options. I put acute on chronic combined systolic and diastolic, acute on chronic diastolic, and acute on chronic systolic, and other, please specify. So he went with his original acute on chronic diastolic. But I killed, two birds with one stone with having it that way, because if diastolic and systolic is listed, I mean, yes, you can combine it, but I like to have the provider write it out.
Mm-hmm.
So it's not, I'm not leaving nothing up to, well, these two are here. No, this is what he said. So I was trying to eliminate having to ask him, did he agree with the systolic and would he combine them? So that way I left it to him to pick the choice. He made his choice and I moved on. But if they had ruled it out, or if they had done whatever, then we wouldn't be, there would be no need for that.
Wow. Shay says, in the medical laboratory field, we have patients' results that automatically gets released to the patient chart if it's negative. We only review if it's positive or flagged for some reason. Wow. See, yeah, it's gonna be a mess. And then they think, and folks, for some reason, folks have been having these conversations that medical coder is going away. I don't even see it. How in the world? Where they going? Other than
I don't
being
see.
moved out by nurses, like
Listen,
so again, you better make sure you keep your skills up. Keep that lifelong learning going on.
oh, most definitely.
Yes.
Good morning.
Good morning.
Good morning.
I just wanted to say that people that believe that medical coding, coders are going to be out of style, basically, that's a false narrative because there are a lot of healthcare systems that are starting to hire people to take training in their healthcare system to become coders. Christiana Care is one of them. They're actually hiring people for a coding training program, and then you'll have a job as a coder.
Is that where's that located?
In Delaware.
Are they allowing remote?
If I'm not mistaken, yes.
So anybody who's listening that's interested in looking for a position and interested in healthcare, it seems like there's a seamless transition. Perfectly, everything.
Yeah, they're
doing what they're supposed to do, but
their information sessions is February 7th and February 8th. When you go on the website in the careers, just put in coding and it'll come up and apply and then reserve your spot. Yep, all you have to do is have a high school diploma, and they prefer you have a chemistry or biology class. Everybody believe I had that. I mean, had that in high school. So
wow.
I think that is amazing because they need to go back to because actually these schools have done the coding industry a huge disservice. And it's just that they have, they're beyond repair at this point. So it is best that these people that you train somebody. That's how I learned on the job training, and it just I just can't thank it enough because you have people who can't. You have people with credentials who can't even properly index. You have people with credentials who can't even recite one guideline. Are you freaking kidding me?
Or wouldn't, like we said, wouldn't know a guideline if it smacked them in the face.
Exactly.
Like, what is that? What are you talking about? Why do you again the why? Why do you think we're doing what we're doing? Why do you think we're providing the education the way we're providing it? Why do you think we coded the way we coded? Come on, y'all.
Because actually, we had a departmental CDI meeting yesterday, and they do some really, really good presentations, like some of the other CDI people, because they really deep dive into these conditions. So they did one of the specialists did a presentation on sickle cell and acute chest syndrome, and she was saying that the case was the person presented, of course, with the fever and something was elevated, so they thought she had pneumonia, but she ended up and of course she had the vaso-occlusive pain crisis. So they ended up doing a workup and she got diagnosed with acute chest syndrome. So one of the other specialists asked a question about acute chest syndrome being present on admission. So a lot of the people, like, they're not quote unquote coders. They have CDI credentials, but their expertise is not coding. So they rely on the encoder. I use the book still. So I explained to them, because she was saying that she picked a different primary diagnosis than the coder because she didn't pick the one with the acute chest syndrome. So she and the other CDI person were kind of like, well, how was it present on admission? So, but the coder was right. So I told him, I said, well, I have a coding background. And when you index by the book, when you go to disease sickle cell and it goes to width, it says acute chest syndrome. So when it has that, it doesn't matter when in the inpatient stay you get diagnosed with acute chest syndrome. When you do, it automatically gets tied to the sickle cell, which is present on admission.
Yep.
So that's how you get to use that versus the occlusive pain, which is not as severe as acute chest syndrome.
Exactly.
So that's why you have to have coders have to be everywhere to explain.
Yes.
You are right. Let's see. The healthcare business consultant says, yes, they have. The schools are the so-called, quote, gatekeepers. They go our word. money grab. Absolutely. And then the product that is coming out of them, blossom.
Well, once these once these HIM schools, find out about this scan that the feds just broke up, it might be a whole lot of RHIAs and RHITs in the next couple months. You never know.
Are you talking about the schools that were giving out false nursing degrees?
Yes.
Yeah, I think the same thing was happening with registered health information technicians too, because a lot of them don't know what they're doing.
Oh yeah, we gonna definitely dig into the information on those nursing credentials.
I'm sorry.
No, you're here. Go ahead.
No, remember when healthcare systems used to pay for people to take coder classes?
It was professional development 101.
Yeah, like they don't even do that anymore.
They won't even pay. They won't even allow. Well, they won't even. They want you to have a credential, but they won't even provide the resources for you to continue to maintain that credential, or they won't even allow you the time to do it. Oftentimes, you hear folks saying that they have to take their PTO time or vacation time in order to go to seminars or things where they can get CUs to maintain it. It's crazy out here in these streets.
Yeah,
but you need me to have this credential in order to do the work.
Exactly. And my whole thing is that I've seen a lot of jobs that are requiring certifications in coding, and they're skipping over people who actually have years of experience doing it, and they just don't have their certification. Why are you not allowing these people to get the certification within the year or 2 years from hire date? Mm-hmm. So you're going to skip over this person's experience because they don't have the certification.
And that should be, again, folks need to understand the art and science of negotiation, because that should be something that's negotiated
exactly
at that time. But a lot of people don't know that they can do that. A lot of people don't.
But
go ahead.
But it's a lot of people can't, because like they are sticklers. Like, because a lot of times, especially when you use third party, now if you're directly talking to somebody at the hospital, that's different. But when you're going through a recruiter, they are, the client is requiring this, and that, and they won't even submit you. Now, I think that just like, Dr. Talk was saying, they do themselves a huge disservice and they miss out on a lot of people, but that really is what happens.
Yeah, because it's like, if you think about it, is there really a shortage of coders, or is there a shortage of certified coders?
Both.
Or is it gatekeepers that are keeping people from getting into these roles? So to your point,
all of the above.
So to your point,
yes.
You eventually y'all know where we come from. You play that game until you get to the person that you need to have the conversation with. And at that point, hey, let's discuss, I may not have XYZ credential today, but let's discuss how I can get there. What opportunities or what resources are you willing to invest in me as I invest in this organization as an employer or employee, to that goal. I can help this organization better with, y'all know how to mouth, sir.
Yeah. You know how to remix and flip it.
and I certainly get the gift of gab, but you got to get the opportunity to get in front of that person.
But
That
that's
is
what I
true.
said. You play that game till you get there, and once you get there, that's when the conversation has. You don't have to have a conversation with the recruiter. You ain't got to have a conversation with HR. You need to have a conversation with the person that you are going to be directly reporting to. How can I help you? Help me help you.
Then this is what I did where I'm at, because I have 2 interviews coming up for revenue integrity and revenue cycle systems. What I did was I applied for the positions, and after a week, when I saw that neither one of the recruiters were reaching out to me, I emailed them and I stated to them, I have over 11 years experience from registration all the way up to coding. Why am I not being considered for an interview? This is ridiculous. And immediately I got 2 interviews for next week.
See, sometimes you just gotta circle back, like, well, wait a minute, hold up, what is happening? And insert yourself in their process.
All right. Welcome to the stage, Renee.
Hi, Renee.
Jump on in.
Good morning. Hey, Jesse. Good morning, Clarice and Dr.
Good
Cole.
morning.
How's everybody?
Good morning.
I just came up because I'm a little bit off topic, but now that just listening to what you all were saying just a second ago, I want to encourage us as a people. Okay, I would like to encourage us to maybe stop when recruiters are saying to us, "Oh, you don't have certain things." Da 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 da. Okay. Why can't we just go to doctors' offices directly? Why can't we just go to nurse practitioners' offices directly and just let them know what we can offer to their business for their clientele? And then we just kind of start scaling out of these companies that kind of seem like they don't want us around anyway. Why can't we just start developing our own, and then you determine when you're ready to go get your certification, or if you're not ready to go get your certification in certain things. And this way we can build our community, and then we can have people in places that we can go, and we know that certain things like being overbilled, or surgeries that didn't happen are being documented, and whatever's going on, we can kind of be more of a community, and we can share this information, and we know what we know, and we can help each other, serve each other better that way.
Girl, you read my playbook? Because you read my business plan in my playbook. What is happening? No, but I absolutely agree.
Yes.
Absolutely
yes.
Agree.
Stop begging for the seats at the table. We sometimes,
come on.
The Lord, He blocks things because it's not where we should be. I know it's scary. I know economically the funding that it would take, but you'd be surprised how many people, if you share not necessarily all of your ideas, but if you talk a certain way, like Jesse said, the gift of gab, but you know exactly what to say and what to kind of refrain from saying, people will fund you. You just never know who's listening, who agrees with what you're saying. Like you guys saying, the documentation and the wound care. Wound care is a $1 billion business. So if you can code wounds, I mean, do you know how many C-section wounds there are? Go find some labor and delivery nurse practitioners and doctors.
Thank you for that.
Go find some diabetic endocrinologist offices and go tell them why they need you, because you could code wounds. So you have a specialty. You know what I mean? So just use your words to get where you need to be. Is the bottom line. It doesn't matter what you're doing, what industry you're in. Use your words to get where you need to be. And if you have to hustle and do it for yourself, and you can only make $500 a day, guess what? At a job, I don't know many people that make $500 a day without overtime.
That's right.
So if you have a goal for your money, every day you should have a goal. It only takes $2,300 and a little bit over $2,300 to make $1 million a year. So when we really start getting serious about what are we going to these people's jobs for, and is it about money? If it's about money, figure out how much money you need to make, and then go and hustle until you make your mark for the day, and then you go sit down. That's it. But I don't want to get off on that. But
girl,
I
love it.
Oh no, thank you for that. I
you.
notated that in my book. I mean, in my notes on my phone.
Oh, good.
And remember, share the information, share the video when it comes out. Other folks might need to hear this as well. So Missy Blue says, I believe all medical coders should have a contract business with hospitals and private insurance companies. Girl, that one too. Don't sleep on these insurance companies, because remember, they audit too. Don't sleep.
And I used to
Noted.
work for one, so they are definitely, they need their coders.
Yes,
They do.
the healthcare business consultant said that's what I'm in the process of doing. Missy says she agrees with the lady right now. So that was you, Miss Renee. She's spot on with that. Yes, you better say it. All right now. All the folks are in agreement with all of that. And I agree as well. You know, we sometimes discount ourselves and our abilities and our knowledge and what we bring to the table. And to both of your points, sometimes we don't need a seat at that table. We got enough resources, ingenuity, passion. We come from a good stock to build our own table, to set up to build the building that houses the table that we built. Come on, y'all. Come on. So I love that. I love that. And that was just to me a positive spin on the end of our conversation today. That was I needed that push myself. I appreciate y'all.
And I definitely think that moving forward, like as healthcare, what we talked about earlier, as it begins to implode, there's going to be a lot more opportunities for entrepreneurs and for people who can be independent and think outside the box, because it's going to be people are still going to be in need. At the end of the day, people are still going to always be sick. Claims are going to always need to be coded and paid. So there's always going to be a need, regardless of how the industry is set up. So
I love it. Cool. So this has been a wonderful session. We are at the top of the hour. Thanks again, everybody, for joining the Saturday morning tea. I appreciate you being here. I appreciate your participation and providing additional information and your thoughts. Speaking all of the things, as Misty Blue says, speak it, sister, into existence with the Most High God. Yes, yes, and yes. So I appreciate all of the insight that we have provided. all of the insight that you all have provided, not only on topic, but also around topic, because all of this is still related and relevant to the information that we provided earlier. So yes, I thank you. So again, I always ask, was the tea spilled today? Hell, I think a whole pot was spilled. Not even the teacup. I think a pot was spilled. Mr. Jesse, with your thoughts.
the tea was spilled, and Renee gave the benediction over the tea spilling.
I feel like I need to put her cash app in there for a donation. Y'all.
No, I don't need that. You know what I need? I need my people to take action, and let's get to this money, and let's help each other get well and stay well. And that'll be it for me. Let give God all the glory and the praise, and we just do what we need to do down here to help each other, because no one else is looking out for us.
Amen.
Let's help each other.
Amen. Well, I appreciate you. I appreciate you coming, and don't be a stranger, man. We're gonna be looking for you on our weekly basis.
Okay. You know what I want to offer, Clarice? I'm sorry to cut you off. There's a new code that I've heard about. I haven't seen it, but it's I don't want to. Let me go right here. I have it right here for you. It is code. Where is it? Oh my gosh. Now that Z as in zebra 28.310. I hear that that's going to have something to do with the V status, and I'm not sure how that's going to play out, but it looks like they're going to have a code that says if you have gotten it or if you haven't gotten it. And so maybe you guys can look into that for us, and just kind of to have a room regarding that, to see how that's going to do the past medical history, because they're going to add that to people's charts and things, from what I hear.
Interesting. And, well, now that you mentioned it, because when they're adding those things to past medical history, oftentimes, particularly if you're thinking about insurance companies, whether they think it's a pre-existing condition for new for new insurance services, that can be something that they would look for to deny
Yes.
on the basis of
Yes.
so y'all gotta think bigger than just
Yes.
this. So yeah, definitely.
Okay.
Definitely.
Thank you.
You
Y'all
are
have
welcome.
a good day. Thank
You
Have a
too.
good
Thank
one.
you.
You too. Also, if you have any, let me show this. If you have any additional questions or things that you want us to kind of look for, make sure you can email me at cwarner@ohioprn.com. If it's something that I can address or answer, I will. If it's something that needs to be directed to Mr. Jesse, the coding nurse, I will definitely send it his way as well, and we can comment on that. I think next week we're going to probably look at that whole nursing piece, but then we're also probably just going to do a Q&A. Just, let's talk about some of the things that we're seeing or questions that we may have that have been burning a hole in our in our head. So let that be our topic for next week. So Mr. Jesse, I'm relying on you to get all the stuff about the nursing stuff. I'll look too, but
Definitely. Oh, I have it all though.
Oh, you ready? All right, you ready? And so if you send those questions in, I guess at the latest by Thursday, it'll give us an opportunity to make sure that we have because y'all know me, I like to make sure I got some research, I got some black and white references to back up anything that I say. So make sure you get those questions out to us, and we'll have a wonderful discussion next week. So again, if this information was valuable for you, help us share this message with others by sharing the video, liking the video, and subscribing to the channel. You can also, which is Professional Reimbursement Network, you can also check out the Coding Nurse channel on YouTube. He has some gems dropped over there as well. Last but certainly not least, to my Clubhouse folks, you can click on the greenhouse to join in on the fun in our club, and you will get notified of our live broadcast, which is every Saturday morning, unless I tell you otherwise, at 9 a.m. Eastern Standard Time. Again, this has been a great session today. Mr. Jesse, do you have any final thoughts?
Once again, thank you for holding space. It was a wonderful room. Glad to be back. I'm glad. Hope everybody has a great week. See you next Saturday.
Definitely. Okay, well, thank you all for joining. This was a great session. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great week. Hooday to the Bengals.
Bye-bye.
Have a good one. Thank you.
Bye, everybody.
Bye, y'all.
Bye-bye.